All right, we have just started the recording of this open meeting in compliance with the CMS guidelines. For the record, prior to doing so, I announce that Palmetto GBA will be making audio recording of the open meeting. Palmetto GBA only recognizes the Teams webinar recording that will be posted on the Palmetto GBA website as the accurate and reliable record of this meeting. We will now begin with the presenters who have previously registered to speak. Before we start, I'd like to remind each presenter to please adhere to the allotted 15-minute time limit. This will help us stay on schedule and ensure every registered speaker has an opportunity to be heard. We can now commence with the first speaker, which I believe is Dr. Vandervaart. Would you please go ahead?
Hello, good morning. I appreciate the opportunity to speak here. So my name is Rob Vandervaart. I am a glaucoma surgeon in Wilmington, North Carolina. And again, appreciate the opportunity to share my experience with iDose here. We can go ahead and go to my first slide. Good. So yeah, the requirement to fail both two different medications as well as SLT is going to significantly restrict access and delay care in glaucoma patients. One of the things that I think is most important in glaucoma is many of our patients require multiple methods to kind of get where they need to go. Medication burden and adherence is difficult. That's something that there's a mountain of evidence to support. There's dexterity issues, issues with dementia, other medical problems that really limit these patients in a lot of cases. And taking an eye drop obviously is more involved in many cases than a oral medication. You need dexterity, you need good vision, which a lot of these patients don't have to be able to do that. There are alternative options such as minimally invasive glaucoma surgery, but iDose kind of represents its own kind of paradigm in the glaucoma treatment. It's the only long-acting pharmaceutical that we have. It's really separate from a glaucoma procedure like SLT or minimally invasive glaucoma surgery because it's actually allowing us to treat a patient with a long-term pharmaceutical. Long-term pharmaceuticals are common in other specialties. Rheumatology probably is the best example of patients who can have a monthly or quarterly injection. This is something that can provide pharmacologic control of their disease for up to and perhaps longer than 3 years, according to the excellent data that we have on the iDose device. And so that's really kind of its own unique set, which has been really meaningful for my glaucoma patients who have been able to take advantage of using this technology over the last 2 years. We could go to the next slide, please. So again, kind of what I referenced earlier. So our glaucoma patients, many of them need multiple methodology to get them to goal and prevent them from progression of their disease. So we always have to look at our patients as individual cases. Treatment decisions have to consider adherence and tolerability, not simply failure of the medication. Again, using an eye drop is different than using an oral medication. It requires being physically able to use both hands in order to get the drop into your eye. It requires having good vision to be able to see the drop, see the bottle and use it in a way that perhaps oral medications may not. The other thing to consider is that patients who are on multiple of these medications, we know, again, the literature is very consistent that side effects increase with each medication that's added and the length of time that it's on it. Rigid protocol requiring a failure of multiple therapies, 2 medications as well as SLT. To my knowledge, there's no other glaucoma intervention that requires something this strict, these guardrails this strict. And this really just doesn't reflect the real world care of our glaucoma patients. Again, iDose is a pharmacologic intervention. So it's not a surgical device. It's not like other minimally invasive glaucoma surgery options that are out there. It's a long-acting pharmaceutical. It's using medication, but just in a way that that eliminates the concerns with patient adherence and difficulty with using. It can be combined safely with cataract surgery and other ophthalmic procedures. The benefit there is that the pharmacologic basis of travoprost, the medication in the iDose system, works differently than other glaucoma surgeries, including SLT and MIGS. Those are involved on increasing trabecular outflow, which is one way that intraocular pressure is regulated within the eye. Travoprost works on a different pathway called the uveoscleral pathway. So it's two separate mechanisms of action, and that's why the data is consistent in showing that combining this intervention with other interventions such as cataract surgery or even SLT, a combination rather than failure, can actually increase control because we're hitting it at two different mechanisms. When I counsel my patients about iDose, I describe it in exactly this way because it is a long-acting pharmacologic option. It is not a surgical, it's not a surgical device like the other options that we have available, including SLT. So it's its own kind of paradigm within our glaucoma treatment protocol. Data continues, or the data that we have continues to support, again, the dual mechanisms that I described. So targeting different outflow pathways within the eye, looking at both uveoscleral, which is where travoprost, the active ingredient in iDose, operates, versus trabecular outflow, which is where pretty much all of our less invasive glaucoma options, including SLT, acts. And so again, these are treating separate mechanisms for glaucoma. The ability to combine a long-acting pharmaceutical working on a different pathway with other glaucoma procedures that are available, including MIGS and including SLT, allows us to treat both outflow pathways and provide better intraocular pressure control for our patients. It also continues to allow us to provide case-by-case personalized glaucoma care, which is so necessary for our patients. Well, anyways, so, from my standpoint, experience of a glaucoma surgeon practicing, it has been that this technology and in a combination with the other options that we have has been a huge benefit for my patients. I think the data is consistent in showing that. And I view the proposed LCD as overly restrictive and putting guardrails around a new technology that we need to allow this subset of glaucoma treatment, the idea of long-acting procedural pharmaceuticals. That's something that has really not been tapped into in glaucoma previously, and we really need to allow this technology to continue to grow to improve our control for our patients. And so I just view this kind of putting guardrails on it this quickly as perhaps too restrictive too soon. And so from my perspective, I would appreciate or propose to either delay or withdraw the proposed LCD as we continue to get more data and further explore the long-acting procedural pharmaceutical space. I believe that's all I have. Again, I appreciate the opportunity to present and share my experience with this technology and for everyone's attention.
All right. Well, thank you, Dr. Vandervaart, for your presentation. I believe the next presenter is Dr. Schodel. Would you please go ahead? Are a few minutes ahead of schedule. If he is not on at the moment, I believe the next presenter after that was Dr. Okiki. If you're on and available, would you be willing to go at this point, and maybe we can get a hold of Dr. Schodel for the next one?
Yes, I'm available. I can speak now.
Perfect. Thank you.
Good morning, and thank you for the opportunity to speak today. My name is Dr. Constance Okeke, and I'm a glaucoma specialist practicing in Virginia. I'd like to share my perspective regarding sustained drug delivery, and specifically the role of iDose when used in conjunction with MIGS procedures. My comments today are based on my experience caring for glaucoma patients for over 20 years, many of whom are Medicare beneficiaries, and my goal today is to explain why maintaining physician flexibility in this area is important for patient care. Next slide. I serve as a lead glaucoma specialist at Virginia Eye Consultants and have spent much of my career focused on both medical and surgical glaucoma management. We have a large referral-based glaucoma practice, and I care for a large number of glaucoma patients that cross a full spectrum from early to moderate to severe disease. Many of these patients are Medicare patients. Over the years, I've been able to adopt a broad interventional glaucoma approach, utilizing medications, laser procedures, MIGS procedures, sustained drug delivery, and traditional glaucoma surgery when appropriate. One thing that has become very clear to me in my over 20 years of practicing glaucoma is that glaucoma is not a one-size-fits-all disease. When we discuss glaucoma treatment, we focus on intraocular pressure, or IOP. But when a patient is sitting across the room from me in our chairs, we're dealing with much more than just pressure measurement. Many of these patients are managing multiple medications, experiencing ocular surface irritation, they're struggling with costs, and just simply trying to remember what can be a very complex regimen every day. And a patient who may be appearing controlled from a pressure standpoint is still carrying a significant treatment burden. And as a physician, when I look at my patients, it's not just our responsibility to lower the eye pressure, but it's also to help them succeed with long-term treatment so they can continue seeing. Next slide. Now, this slide is really the foundation of my comments today. When we talk about eye pressure lowering approaches, there's two main outflow pathways that we're trying to help enhance. The trabecular meshwork outflow pathway, which is considered the conventional pathway, and the uveoscleral pathway, both of them allowing aqueous humor to flow out. Now, with MIGS, it's the trabecular meshwork pathway that was what we're enhancing, and this helps to improve the drainage and lower eye pressure. With iDose TR, it's a sustained travoprost delivery of a prostaglandin analog that enhances the uveoscleral pathway. These are two different pathways, two different mechanisms, but they have a shared goal of lowering the eye pressure. Why does complementary therapy matter? Well, think about it. We've been using complementary therapy in our eye pressure medications. We have 6 different classes of medications, and we use them not just one at a time, but many times in combination. Why? Because they have different mechanisms of how they work, and they can be complementary, adjunctive. They can add. So when we think about the trabecular meshwork pathway with MIGS, this enhances the trabecular outflow pathway. When we think about iDose TR, this enhances the uveoscleral pathway. So combined, they are complementary, not redundant. What does that equal after the procedure is done? Better comprehensive eye pressure control. This typically allows patients to be on fewer medications, which means less burden, improved adherence, and improved quality of life. We're also preserving the eye for future options that may need to be done in the patient's glaucoma journey, which is typically decades. So 2 different pathways, 2 different mechanisms, but one goal to help each patient one at a time. Next slide. So when we are thinking as a surgeon for our patients, we're trying to be their advocate and think about how we can have their benefit, risk-benefit ratio and balance of the benefit. So when I approach the OR, I'm thinking, what can I do in the OR to help this patient best in this episode? So that may mean multiple things, like cataract surgery to help them see better, plus MIGS to help enhance their trabecular outflow pathway and lower their pressure, plus iDose, which then also helps lower the eye pressure, the uveoscleral pathway, or MIGS plus iDose. It's one procedure at a time. And what does it do? Give me multiple benefits. Lowering IOP, reducing medication burden, improving adherence, using multiple pathways. All of this is individualized care that is complementary so I can get a better outcome for the patient that's sitting in front of me. Next slide. Now, when we think about patients and how they adapt to treatment, one of the most interesting observations came from my own work when I did some surveys looking at how patients react to their medications and options. I did a survey and asked patients about how they do with medications, and many of them said they have side effects. Many of them said they have financial burden. Yet when I asked them whether they were doing okay with their drops, many of them said that they were doing okay. But when then I further asked them, would you be interested in procedures that could reduce or eliminate your dependence on drops? The vast majority expressed interest. What does that demonstrate to me? Something very important. patients will often adapt to treatment burden rather than complain about it. And just because they're accepting the treatment, it doesn't mean they wouldn't prefer a better option if they knew they had them. Next slide. So, what did I do? I said, I need to have my patients know that there are options. Unfortunately, I have a very busy glaucoma practice, and I love to tell every patient about every option that they have. But what I can do is have them know by putting a poster on my wall, because patients have time to wait for me and look and learn. And so this exact poster I put on my wall. And what happened? Patients began initiating conversations. Patients who had never previously mentioned that they had problems with their medications started asking if they were candidates for these alternatives. Some wanted to reduce their medication burden. Some wanted to avoid side effects. Some simply just wanted to know that they had options. And what this experience reinforced was an important lesson. Patients can't ask about options if they don't know they exist. We need to bring awareness to change the conversation. I went further recently to look at some of my internal outcomes, my outcomes of patients who've had mixed procedures in combination with each other and mixed procedures in combination with iDose. And what I found across the board was that patients with the highest medication burden experienced the greatest medication reduction. I also found that a good majority of the patients were able to reach their target eye pressure outcomes. And what this told me is, in clinical reality, there are multiple procedure combinations that are being utilized in routine clinical practice, like my own, and these different patients are getting treatment combinations, and they're working to help these patients. Why? Because I had the flexibility to choose these individualized care for my patient. My concern regarding this draft of the draft LCD is not that every patient should receive combined therapy. No, that's not what I'm advocating. My concern is that the proposed restrictions could remove an important treatment option from physicians who determine that a patient may benefit from a complementary approach. The issue is preserving clinical judgment. The issue is preserving physician flexibility. The issue is preserving the ability to individualize care. So my request is very straightforward. I'm asking that Palmetto preserves physician-directed decision-making regarding the use of sustained drug delivery therapies in appropriate patients. Physicians should be able to individualize treatment for Mrs. Jones. They should be able to address adherence challenges for Mr. Smith. They should be able to allow Mrs. Jackson treatment burden when she's struggling, and be able to utilize complementary mechanisms when we feel they are appropriate. Glaucoma is not a one-size-fits-all disease. I need my tools to handle the load of the patients who are in front of me the best that I can, with treatments that have been proven to be effective. Next slide. So I'd like you to leave with these final thoughts. MIGS and iDose TR are not complementary. They are complementary and not redundant. They have different pathways with different mechanisms serving one goal, which is to help lower eye pressure for that one patient who's in front of us at a time. Preserving access to these options will help us focus on what matters most, being able to protect the vision while reducing treatment burden and providing an improved patient experience. I took a Hippocratic oath to do what is best for my patients. I just want my options to be able to do so. Thank you for your time and your consideration.
Thank you for your presentation. We're looking for Dr. Schodel for the next round of for the next presenter. If he's on, could you please go ahead? We will give it a minute or two to see if we can get in touch with him to see if he's available. And we'll update you shortly. While we're waiting for Dr. Shodel, I do want to mention that written comments may continue to be submitted for this on or before July 4th. So all written comments we can go through the Medicare coverage database or go directly to the email address for b.policy@palmettogba.com. And we're going to give it another minute to see if we can get a hold of Dr. Shodel. If he shows up, we can begin presenting. And if not, we will close the meeting. All right, we'll give it one last call for Dr. Tad Shodel from Vista Eye Center. If you're on, please proceed with your presentation. And if we don't hear anything in the next minute or so, we'll go ahead and close out the meeting. We will conclude, this concludes our presentations for this open meeting for Jurisdiction M. As I mentioned before, written comments may continue to be submitted on or before July 4th. Thank you all for attending, and we'll end the meeting at this time. Thank you.